We acknowledge that the country for Aboriginal peoples is an interconnected set of ancient and sophisticated relationships, from Sydney to the Southern Highlands to the South Coast, from freshwater to bitter water to salt. We pay our respects to leaders past and present. This video is a collaboration between the Illawarra Shoalhaven Local Health District and the Palliative Care Outcomes Collaboration known as PCOC. This is a second video in a series of 3 about allied health using the PCOC assessments. In video 1, we described each of the 5 PCOC assessment tools and how they work together as a holistic assessment to inform the care plan and identify patient and family and carer needs.
In this video, we will hear from members of the Illawarra Shoalhaven Local Health District Allied Health team about how they use the PCOC assessment tools. A key factor for using these tools successfully is effective communication. Using plain language and interpreters when needed is critical to engage individuals in discussions and decisions about their care.
In the Illawarra Shoalhaven Local Health District, we made completing a full PCOC assessment mandatory as part of our palliative care allied health practice. PCOC is such a useful screening tool for every discipline to be using to make sure the right person is seeing the client at the right time. As members of the allied health team, we have found that parts of PCOC have been complementary to our discipline assessments, and some we've just had to make sure to add. The following discussion will show the variety of experiences that the Illawarra Shoalhaven Palliative Care Allied Health team have had when using the PCOC assessment tools. The first tool is the Resource Utilisation Group's Activities of Daily Living, or the RUG-ADL score, which measures motor function in daily activities in 4 areas of mobility, toileting, transfers and eating. It helps to identify the assistance a person needs, and it is clinician rated.
As a physiotherapist, I determine RUG-ADL through my standard assessment, including assessing mobility, transfers and functional mobility, including getting on and off a toilet. Whilst I'm also completing an SAS assessment as well, talking about appetite, I'll add additional questions to determine independence with feeding. For example, I'll be asking if somebody has any issues with their appetite, and then a follow-up question asking whether they're able to feed themselves independently. Answer yes to that, I know that their RUG-ADL score for feeding is 1.
So in a typical speech pathology assessment, I may not cover all the areas such as transfers or toileting. Instead, I may ask them something like, my understanding is that previously you were independent with going to the toilet, getting in and out of bed, transferring in and out of a chair and eating. Is this still the case, or are you needing a little bit of help with any of those things now? If they were needing help with, say, something like getting in and out of bed, I would now give that a RUG score of 3. So overall, for a patient who is still able to feed themselves but now needing a little bit of help getting in and out of bed, I would give that a RUG score of 4.
The next tool is the Australian Modified Karnofsky Performance Status, or AKPS, which is a snapshot of the person's overall performance. It is a single score between 0 and 100 and is based on observations of the person's ability to perform tasks. This is clinician rated. Similar to the RUG score, a clinician may be able to determine this score from information gathered in discipline-specific assessments. Other times you may need to add in a question to help clarify.
So when assessing for AKPS, I can determine this in my social-work assessment, as I tend to ask a person about their current care needs and level of function. However, I could ask something along the lines of, from today's discussion, it sounds like you're needing more help with your showering, medications, and walking. So I can then ask the person, do you need help from someone 50% of the time in your day?
As a speech pathologist, I would word the question as, I can see that you're quite independent. Are you needing any help with any of tasks these days, or any tasks getting harder than they previously were? We ask this to capture change in functioning, and it can allow us to determine if there's any resources or aids that are required.
The next tool is the Symptom Assessment Scale, or the SAS, which is a measure of the amount of distress caused by 7 of the most common symptoms. This is client rated or can be rated by a carer if the client cannot. The SAS, along with the problem severity score, is what determines someone's phase. Using the SAS ruler helps prompt you on the symptoms to ask about and gives a visual and numerical scale for the person. You can look on the back and ask through each symptom, whilst the visual guide is displayed to the client.
When completing the SAS, I might say something like, you've mentioned you're not feeling hungry anymore and you've got no energy during the day. I'd ask, is their lack of appetite bothering them, and how they would rate that on a scale of 0 to 10, with 0 being not worrying them at all and 10 being the most worry. And then I might ask them, what about their fatigue levels and are they bothering them?
I find that I can weave the SAS questions throughout my assessment, create a free-flowing, fluid conversation. I do this by asking questions around symptoms, such as, are you having any issues with your breathing at the moment? And if so, with what activities they're having issues with their breathlessness, and on a scale of 0 through to 10, what severity is that symptom affecting your quality of life or causing you distress within the past 24 hours? If they're unable to answer that question confidently, I would use the SAS ruler to allow the patient to confidently point to the face or colour that best depicts how they feel that that symptom is being managed at the moment.
So sometimes I like to ask someone, do you have any pain at the moment? And if so, can you tell me more about that pain? I would also ask, how would you rate your distress score on a scale of 0 to 10, 0 being no pain and 10 being the worst? If the person would score an 8 out of 10, I would then ask, have you taken your pain relief as recommended? And I'd reassure them that I would discuss it further with the team and request for review as soon as possible.
It is important to not just obtain a score for SAS symptoms. We need to have some follow-up questions, such as, have you taken your prescribed medication today, so that we can help to address the concerns and gather appropriate information to escalate to the wider team.
Next, we have the Palliative Care Problem Severity Score, or PSS. It measures the severity of symptoms in 4 domains of pain, psychological, spiritual, family or carer stress, and other symptoms. PSS score also determines the phase of a client. It is a clinician-rated score and is based on clinical observations, but often you need to ask some more questions to determine a score.
Yeah, so the PSS is often part of my socio-ec assessment, as I'm often asking a person how they're coping emotionally. So normalising their experiences and providing psychoeducation of a range of emotions that they may be experiencing. So from sadness, anger, and even a sense of hopelessness. So a question I might ask is, if you feel comfortable, do you mind sharing how you've been coping emotionally since your diagnosis and with the recent changes in your condition?
For PSS, the patient or carer might outline some concerns if I ask a broad, open-ended question like, how are you coping at the moment? I can ask this to both the patient and carer separately so that I can determine the carer or family PSS and as well as the patient psychological PSS. But as holistic clinicians, you'd already be looking out for indicators that the person might need some more support. Their score for pain is based on my observations during my assessment. So I'm looking for things like any signs of pain, such as groaning, fidgeting, moaning, facial expressions. Other symptoms could be anything reported by the client or carer, such as saliva, coughing, edema, cognition, communication. It could be anything they report, or you may need to ask, is there anything else bothering you?
The final tool is the palliative care phases: stable, unstable, deteriorating, and terminal. Phase is determined directly from assessment results. The PCOC lanyard cards provide a simple guide for determining which phase an individual might be based on their assessment scores.
Remember, you're screening for symptoms and problems, so you don't need to solve the issues you find. You just have to know when to escalate the problem to the right team member at the right time. Having the same language and being confident to use this within the wider MDT is beneficial. I can say at a clinical huddle when a person is scoring 9 out of 10, and everyone understands this as an urgent need for intervention. Completing the PCOC assessment is just good clinical, holistic care. So just give it a go.
This concludes video 2 of this 3-part video series. We thank the Palliative Care Allied Health team for their time and ongoing support for PCOC. patients and their families and carers. We would also like to thank the PCOC consumer representatives for their valuable input.